going to have a basic introduction, and then we're going to have opening remarks by Dr. Fejuru, after which we're going to have two presentations, one from NHIA and then one from you. And then afterwards, we're going to go into the panel session where we're going to have the speakers ask questions and have questions from participants as well. And it's just a general discussion on improving quality, access to quality healthcare and the role of health insurance. I hope that answers your question and clarifies things.
Yes, thank you. Yes.
Okay, ma'am. Thank you. I'm just still trying to wait for Dr. Curfy, who's representing NHIA. So hopefully in another 2 minutes, he'll be here. Thank you. Good morning, everyone. Thank you to the people who just joined. Please feel free to drop your name, where you are joining from, the organization you work with, your position if you like. It just helps us know who is in the audience and help us direct the flow of our conversation. Thank you very much. Also, please feel free to share the link to your colleagues or anyone else who's not yet here to join the conversation. Thank you.
Okay, thanks. Let me send to my colleagues.
Thank you. Colleagues, friends, platforms, let's all talk health insurance. No, not the same link that was shared to the panelists. There was a registration link that was not the one that was shared today. Any link you received before today can be shared, but not the one from this morning. That one is unique to panelists. Thank you. My colleague would also share with you.
So those ones one level. How would you see? Yes, don't take any how we do something on it. My name is going to look in the land water.
Mm.
Please drop your comments in the chat box. I can see a hand up. If you have a question, you can drop in the Q&A box. A link has been shared in the chat box. So you can please use that to share to your colleagues, your friends, whoever else you want to join. Okay, so while we wait. Okay. Thank you, everyone. While we wait, we will just kick off, and hopefully our speaker and other panelists will join us in the course of things. Thank you for your interest in the conversation today. We're going to be discussing making quality healthcare accessible to all, the role of health insurance. And this is actually the second of a two-part conversation. The first part was held on Twitter on Tuesday, and it actually was pretty engaging. We had over 1,000 people touch base, check in at some point during the conversation. And I think that just goes to show that there's actually an interest in health insurance. Like, people actually are interested, as we possibly would have thought that, oh, health insurance uptake is poor, so maybe people are not interested. But it was actually a really good conversation, and we had different speakers. We had Dr. Lara Roberts, who is a consultant, public health and senior lecturer at Ruth. We had Ms. Toyin Adeshola, who is here right now. She's the founder of Sickle Cell Advocacy Management Initiative. We had Dr. Chinonso, who is known popularly as Aproko Doctor, a health communication behavior change specialist expert. He's created his niche in that. And then we also had Mr. Nonso Operum, who's the founder of Sosuke. And it was interesting because Sosuke and SAMI, the Sickle Cell Advocacy Management Initiative, provide health insurance for vulnerable populations, although they define vulnerable populations differently. But it was, I think you can check out the recorded conversation on Twitter. It was pretty interesting, and I think that everyone should actually listen to it. It would shed some light. Again, please, if you have any comments, drop it in the chat box. If you have any questions, you can put it in the Q&A box. It will just help us filter. Also, feel free to let us know who's listening in, so your name, where you're listening from, your organization, anything, so that we're making sure the conversation is relevant to you. Yeah. Thank you. So we are still waiting for a few of our speakers, particularly our first presenter, but maybe we'll actually, if we start and he's not here, we might go to the second presenter. Okay. I don't see any introductions in the chat box yet. Feel free, don't be shy, drop your name, any questions you have, so that I see the chat box might be disabled. Okay. Correct him, please, the chat box might be disabled. Please look into that. Thank you. We will look into that. So the agenda again is we're going to have basic setting the scene, ground rules. And then we're going to have welcome remarks by Dr. Fejiro Chinyewoko, who is actually the general manager for NSSF. And then we have a presentation from NHIA, and then one from Federal Competition and Consumer Protection Commission. Sorry, that name is typically a handful. I have to think through it. So thank you anyways. And hopefully the chat box will be enabled soon and then people can comment. Let me just take a look. I still don't see. I still don't see Dr. Curfew yet. But
I'm online. I'm listening to you. I'm online.
Oh, okay, what are you?
You've been as a panelist there.
Okay,
Oh, okay.
It shows my name. Okay, so can you just rename yourself? Thank you.
Okay,
Yeah, that's
beautiful.
helpful because I've honestly been waiting to have you.
I've been online
Okay.
actually. Yeah.
Yeah, just rename it so that everyone knows who's speaking and you know.
Beautiful.
Okay, great. Thank you so much. So again, anyone who's just joined, my name is Ameze Guavoin. I'm the programs manager for Nigeria Solidarity Support Fund, and I will be the moderator of this conversation today. Thank you for joining. Thank you for your interest in this conversation. Great, I see that the chat box is now open. Please feel free to introduce yourself in there so we know who we're speaking with and can direct the conversation right. We can answer your questions in a way that's relevant and our comments will be relevant to you. A poll will also be dropped in the chat box. It's basically a short survey, 60 seconds, 90 seconds, just to show us where people are in terms of health insurance, what people think about it, attitude and actual attitude towards health insurance. We know that most people that have health insurance have it because their organization that pays for it, or there's a mandatory contribution. And we want to know if your office wasn't paying or if you weren't mandated to contribute towards health insurance, would you pay for it? This will help us in our advocacy and further conversation. Thank you very much. Just a few ground rules before we start. To our speakers, feel free to turn on your video if that's okay. Stay muted, please, if you're not speaking, so you're not speaking over someone else. Put up your hand if you want to contribute to something that someone else has said. Thank you. I see some beautiful faces, but I think it's only the females that have their cameras on. I hope there's no gender bias right now. But thank you. Because you're not listed as a panelist right now, please use the link that I shared this morning so that you'll be a panelist and you'll have a mic and can speak. If you're having any challenges, and then please rename yourself because you actually might pop up. Oh, okay, there's another Ameze. Please rename yourself if you're here and I share the link with you so that we know who is here and who isn't. I think that has been part of the challenge. Thank you so much. Yes, and then for our participants, please use the chat box for any comments you'd like to share and use the Q&A box for any questions that you may have. Thank you. We'd love to hear from you. We would love your active participation. Thank you so much. That's basically it for now, and I think that we can jump right into it. I look forward to having a fantastic conversation. And I would, at this point, like to call on the General Manager and CEO of NSSF, which is Nigeria Solidarity Support Fund. She is Dr. Fejiro Chinyewoko. She's going to give welcome remarks. Thank you so much.
Good morning, everyone. Just waiting for the feedback.
We can hear you loud and clear.
Okay, nice to see you, Amazing. You're looking really good here. So, good morning.
You,
20s.
okay. We lost you for a bit,
Oh, okay.
but you're back now. We can hear you loud and clear.
So I was saying thank you to all the speakers for agreeing to join us today. And thank you to all the attendees for joining us. I promise that this will be worthwhile use of your morning. I'll give an introduction about NSSF, and just to say, Nigeria Solidarity Support Fund is a not-for-profit organization that was vetted as a result of a partnership between Global Citizens and the NSIA. Global Citizens is an international non-for-profit focused on ending extreme poverty. And the NSIA is Nigerian Sovereign Investment Authority. They are fund managers, but they are also a government parastatal. They came together in 2020 during the heat of the pandemic to create NSSF. And the reason behind that was because Global Citizens realized that while they were ending poverty, the health system in Nigeria was really behind in certain gaps pre the COVID and during the COVID. And health system needed to be strengthened so that people are even alive before, while they continue the drive for end for poverty. So we created NSSF, and NSSF was supposed to be and is supposed to be a fund organization that mobilizes resources from various categories of donors and partners, and then allocates those resources to high impact intervention areas that would help strengthen the health system in Nigeria. NSSF focuses on three main priorities, and the first priority is supporting the vulnerable people. We know that while there are health care gaps in Nigeria, we know that the vulnerable suffers most from these gaps in Nigeria, and so the focus was for vulnerable people. And then the second priority area was to strengthen the health system resilience, such that the health system is able to withstand the impact of a shock, a pandemic, an earthquake, a natural disaster, able to withstand the impact of any shock to the health system, focus on the primary health system, because we know that the primary health system is the bedrock for the health system. And lastly was to reskill and retool the Nigerian youth, and a special focus on Nigerian youth because we know that they're the majority of the population in Nigeria. They are also the working class generation, and so if they are not equipped, they are not able to stand, and they're not would eventually impact on the health system. So NSSF was formed in 2020 to achieve these three giant priority areas. And we are to do that by gathering funds and as well identifying intervention areas. And one of our focus in the priority area is to increase the universal health coverage in Nigeria. And we know that in order to get to universal health coverage, we have to begin to speak about health insurance. And that's why we're here today to brainstorm, to share ideas, to come up with solutions that we can, as a fund, present to the government, but as well help the government by providing that additional resource they need in the health intervention space. We also know that one major effect of not having health insurance is the financial catastrophe that can occur as a result of an illness in a family. And we don't want that to happen, seeing that the poverty rate in Nigeria is already above 50%. health interventions, unplanned health interventions, most of the times they are not planned, can further worsen the poverty level of Nigerians. And that's our passion today. And we are coming here to rub minds with you on how we can move this forward. This is one of many series we do quarterly. We call it a fireside chat because we are supposed to sit together and brainstorm and banter and talk about the gaps, but most especially, what are the solutions that we can move forward with. We have it quarterly, and this quarter has been dedicated to improving the health access with special focus on health insurance and how that would improve our universal health coverage in Nigeria. So welcome once again, and feel free to join in the conversation. Don't wait for a special Q&A session. Just drop your comments, your questions, your anger, whatever it is that you have to share in the comment section, and we shall be able to we'll look into answering and providing discussions on every of those points. Thank you, and over to Amaze.
Thank you very much for that warm welcome and detailed overview of NSSF. Thank you again, everyone. Please feel free to introduce yourself. I see some people have done that in the chat box. We would love to know who's listening and to speak in a way that would be relevant to you. Thank you. And so without much ado, we will go into our first presentation by Dr. Kurfi Abubakar, who is the Deputy General Manager and Head of Policy, Planning and International Collaboration, Division of Nigeria National Health Insurance Authority. Just a brief update on who Dr. Kurfi Abubakar is. He's a medical doctor with a master's degree in public health and an MBA in international healthcare management. He is presently a Deputy General Manager and Head of Policy, Planning and International Collaboration, Division of Nigerian National Health Insurance Authority. His major responsibility is to coordinate and implement interventions to advance the course of universal health coverage in Nigeria. In addition, Dr. Kurfi also combines health and social science research under the NHIA with a focus on strengthening the health financing system to improve the functioning of the health system. So we trust that we'll be hearing great words from him today. Thank you, Dr. Kurfi. You can go ahead and share your presentation.
Okay, thank you. Are you seeing it?
Yes.
Oh, beautiful.
Yes, great.
All right. Good morning, all.
Good morning.
And thank you for this opportunity for me to share what we do in the NHIS, and briefly also to really give a small talk on the role of quality healthcare, in terms of, how it can actually serve as a catalyst for the attainment of universal health coverage. Thank you so much also for that generous introduction, and I'm happy to say I am really honored to stand in the midst of this group of people to share the little that we do here. As a background, my presentation will focus on the following outline. We will briefly talk about what is quality, and then we talk about the dimensions of quality of care, and then we'll look at the cost of quality in healthcare. And then we'll look at also the importance of quality as far as healthcare is concerned. Then I will attempt to link quality of healthcare with health insurance. This is very important because we are seeing the expansion that is happening in the country in the health insurance space. We are aware of a lot of developments that are happening in the health insurance space, principally the passage of the NHIA Act, this new act that has made health insurance mandatory for all Nigerians and has also given legitimacy to this decentralization of health insurance at the state level. And it has set the stage for massive expansion in the health insurance space. So quality has become a very important lever, for linking, for increasing uptake to health insurance. And then we'll also speak about why quality matters in healthcare. And I'll just give some few recommendations and I'll highlight some challenges. So as a background, I just want to say, what does quality means? And this is very important to really highlight that quality means a lot, different things to different people. There is a lot of perceptions and interpretations of what quality is as far as healthcare is concerned. And so there is no one single definition that you say fits in to the definition of quality. This matters to also, it's affected by regions, by locations, by individuals, by personalities. I give you a local example. If you come to Africa, or narrow it down to Nigeria, principally also narrow it down to Northern Nigeria, I want to give a local experience that happens to me. I participated in this as a mystery patient in a teaching hospital in Nigeria, just to observe what is the average time for an NHIS patient to be seen in a teaching hospital. So I camouflaged as a patient. I sat down in the OPD, and I tell you, before I could see the doctor, it took me 1 hour, 48 minutes to see the first doctor. And before I could round up my test, it took me another long period of time. And so when I came back, I was really not happy, I was sad, but I asked the people that were staying next to me that, can you imagine after waiting for so time, just now that I'm seeing the doctor? And the person told me that I'm happy, at least I've seen the doctor. So you could see the perception, of people. The fact that these doctors are not available, that a patient has come to see a doctor no matter the time that he stays, to him, that is quality of care. So subjectivity is a very important variant when determining what quality of care is. And therefore, when you're assessing quality, it's very important to look at it from the point of view of the patient, but also from the point of view of the service delivery. And so assessing quality is multidimensional. That's what I'm driving at. And so all this chaotic slide that has just gone to show the various interpretations and definitions of quality, for me, it's just to show that quality cannot really be defined in a single or straight line dimension. But there is a very important saying here that says quality is everyone's responsibility. This is very important. And especially in the healthcare system, the guard at the guard at the healthcare center, the cleaner, the nurse, the lab scientist, up to the level of the management at the top. We all need to realize that quality is an important part of our responsibility, and we make that conscious effort to actually, ingrain it into the systems that we operate on. And so, but for me, there's also a definition of quality that I really find very, very interesting. And I have actually held on to it as my own ideal definition of quality. That is the definition by the Institute of Medicine. It defines quality from 6 dimensions. It says any healthcare service should be safe. So safety here is that treatment helps patients and does not cause harm. Do no harm is a cardinal principle of medicine. Not only medicine, but any other practice in the healthcare system. It is a cardinal law that the patient that comes to see you should live better off after seeing you. So do not cause any harm when providing treatment. That service should also be effective. So where possible, the treatment should be evidence-based. And this is very important because doing treatment without evidence leads to wastages and serious complications, both for the patient and for the system. I would explain some points down as we go. That service should also be patient-centered. So patients should be treated with respect, and health professionals need to take into account each patient's values and about health and quality of life, and be responsive to the individual variances and needs. So this is also extremely important. You need to be conscious of the people's values and perceptions. And these values are determined by a lot of factors. Religion plays a role, culture plays a role, tribe plays a lot of factors. So you need to put this into the context, and therefore you see the patient as that from that holistic point of view. Timeliness. patient gets the care they need at the time when it will do the most good. And so the determination of the most good is very important here, because if, and this narrows down to the example I just gave. So if a patient, for example, that has severe malaria has to wait 1 hour 48 minutes to see a patient, even if he's happy that to see a doctor, sorry, even if he's happy that he has seen a doctor within that time, the damage has been done. And therefore that cannot be said to be quality healthcare. So perception of the timeliness of a service is that this time should be, the services should be provided when it will do the most good for the patient. And it should be efficient. Treatment should not waste resources. I will speak a lot about cost when we go down, but in terms of health insurance, for us, this is a very important variable. Efficiency is an important aspect of healthcare, and especially health insurance, because for every patient that walks into the hospital, there is a cost attached to that patient. And so we try as much as possible to provide value through quality services without wasting the scarce resources, because those resources can be used to provide service for another patient. And so efficiency is an important dimension to health service delivery as far as health insurance is concerned. Equity. Everyone is entitled to high quality of care, irrespective of his characteristics. This is very important, both for the public and for the private sector. But in the health insurance, this is also very, very important. So irrespective of the contribution status that you do, we try as much as possible to ensure that you get the same quality of services. And for equity purposes, not only the same services, but also services based on need. So the services you get are based on the needs that you have as a patient. So for me, I try to contextualize quality from this dimension. And one of the things that I also did, that recently I got a fellowship to do a study on the comparative analysis of perception of quality of care from the perspective of insured and non-insured Nigerians along various states, looking at these 6 dimensions. And I tell you, the findings are very interesting. You know, payment for healthcare through health insurance is an important lever for changing, for affecting quality of care. You find out that the more resources healthcare facilities have, the more they are able to get, the more financial resources healthcare facilities have, the more they are able to provide those services, to provide services that are qualitative to patients. There is direct correlation between health insurance, payment to healthcare facilities, and improvement in quality of services. And so this is just trying to give you an idea of what quality is, you know, in how service delivery is in Nigeria. The first picture is a hospital I visited in Uyo in Akwa Ibom State. And all these clients you are seeing, they are waiting for one doctor who told me that he has been in the hospital. He did night duty the last night, and he came back as early as 7 to see these patients waiting for him. So you could imagine the degree of burnout that can happen. And then with this burnout, the error rate, of course, will increase. Then these other ones are healthcare facilities across various locations of the country. And of course, you can ask yourself what kind of services can be provided in these particular locations. And these are primary health centers, which are supposed to be the bedrock of health service delivery in Nigeria. And until and unless we improve quality at the PHC level, we are sure going to miss it. Yeah. So these are the dimensions of quality that I just want to mention. From the patient, his timeliness is important. Continuity is very important, and it's equally very important in health insurance, where services are tied to contribution. So this is why we ensure that every person that is covered in health insurance remains covered for the rest of his life. We don't want you to be covered this year and next year you are not covered. You know, and then respect, care, safety, effectiveness, affordability. Affordability, I just want to really go to town on affordability. We want healthcare services to be affordable. I'm happy the first speaker that just spoke has laid some foundation on catastrophic consequences of healthcare as far as service delivery is concerned in the country. So we need to see health insurance as that most important vehicle that can provide the most effective healthcare services to the most vulnerable in our society. It's only through healthcare, health insurance, for example, a villager in the extreme age of FCT villages, maybe in Abaji, in Kwali, can access services, in national hospital without, any form of financial hardship, because his contribution covers him. And because of the principle of solidarity and cross-subsidization in health insurance, where the rich pays for the poor, the young pays for the elderly, the vulnerable can be able to get the same important because in healthcare, there is so much asymmetry of information between the doctor and the patient, asymmetry also of knowledge, because you know more than the patient. And that's why the healthcare market is not a competitive market per se. So you need to communicate to the patient and tell him these are your problems, these are the perceived solutions, and this is the role that you play, and exercise. And these are the follow-up that you need to do. That open, transparent, and sincere communications needs to be enshrined in our healthcare system. And this is a very important area that we really need to improve upon in service delivery in the country. Privacy or confidentiality, service availability, accessibility, and equality and equity. For the healthcare provider, ensure that those services are available and that you have the manpower that is competent and capable, and that you make your workplace safe, and then you create that opportunity for improvement for the staff, and then you pay and reward systems. So the pay and reward is an important factor in healthcare. It's globally established that performance and payment is a very important lever for strengthening performance of healthcare workers. And then support and cooperation, and other benefits through equity and equality. For the healthcare manager, you have to manage efficiently and effectively, and then you ensure that you set targets and you link these targets to remunerations or compensations. And then you have adequate time to give care, and you also empower staff through supervisions, and then provide resources that are needed to provide those services. With regards to health insurance, I'm happy to say through the health insurance, the National Health Act has made provision for the Vulnerable Group Fund, which aims to cover 83 million Nigerians with vulnerable Nigerians with healthcare. The basic healthcare provision fund, which the country is also implementing, is already covering a huge number of vulnerable Nigerians at the state level. So already some form of resources are already going to the healthcare facilities. We need to design mechanisms and enforce these mechanisms to ensure accountability at the PSC level, and to also ensure that these resources are reaching the ultimate beneficiary, which is the patient or the enrollee. So what is the cost of quality? First of all, there is we need to understand there is what is called prevention cost. So there is cost that you incur to prevent defective units of services from being produced. In healthcare, this is a very common complaint that we receive. People that have, fractures, and then they go to a hospital. You say there are implants that are, this type of implants are good, these ones are substandard, these ones are African, this one are this country, this one. So in trying to save costs, for example, you may end up choosing the implants that is below what you are requesting for. If there are complications, we need to open up, and then you also replace with the expensive one. So what I'm trying to say is that in health insurance, prevention is cost saving, and is an important aspect of quality of care. The woman that has 7 children, if you give her family planning, you prevent rupture of the uterus, you prevent maternal mortality, you prevent the child that is giving birth from having complications, and this saves resources for the system. Another very good example is mosquito nets, for example. If you supply preventive malaria services to your community, and you reduce the cost of healthcare as far as following with malaria is concerned. And if you ask our various state health insurance agencies, they will tell you the major driver of cost as far as health insurance is concerned is malaria. So those things that you can prevent, as much as possible, emphasize prevention as cost saving. Appraisal cost. You know, so before you give something to a patient, you need to actually do some form of appraisal. Is this thing good enough? Is it not good enough? And mostly this appraisal happens through an expert. You need to hire a consultant to say, okay, do we provide these services? Or we carry out a research to ensure that whatever you are providing is, of course, of good enough quality to avoid this. Of course, there is cost of doing business and providing service. That's also very important. Then other very important cost, is the external cost. You know, so this cost can be both internal and external. And so for internal costs incurred when services are identified as defective before they reach this, and this mostly happens with appraisal. And then when services are identified as defective, yet they reach the client. So these failure costs are very, very important. In the first case, in the internal, you have to replace. In the second case, externally, you also have to replace, but also manage complications. So you are better off trying to avoid these costs, you know, than going ahead to provide services that will cause complications. And there is a cycle I put here, which I call the cycle of abuse, which is very common in health insurance: misuse, overuse, and underuse. Now, let me give you the instance of overuse. Overuse is very common as far as health insurance is concerned. CT scan, MRI, or even ultrasound. A woman who goes for antenatal clinic and they check and say, your baby is okay. The heart sounds are there, everything is, position is there. She will say, no, sir, I want ultrasound. But you just had ultrasound last week. No, today I want to have ultrasound. Tomorrow I have ultrasound. You know, so that high demand for services, even though they are not needed. CT scan, for something you have, a child has bronchopneumonia. For something that simple X-ray would pick, you say you want to have a CT scan or an MRI. The higher the services, the higher the cost. And so this overuse of services, they can be essential or non-essential, leads to cost in healthcare, and it's a compromise on quality. Because time spent doing services could have freed up resources to be shifted to other areas. Underuse is also a very common form of abuse as far as healthcare is concerned. You need a service, but because of one factor or the other, you tend to underuse that service. For example, if you come to a hospital, if you are paying, okay, I will go to some extent to the payment methods that we use. If you are paying hospitals capitation, for example, simply capitation means you pay them money upfront, whether patient come for services or not. And so because they know that they have already received this money from you, they tend to shift away responsibility of care to the secondary level of care. They simply refer. You know, so this is an underuse of services in their own facility because they want to ensure that they transfer the cost of seeing that patient to another facility. Misuse is very common, and it's more common with drugs. You go and see a patient as a doctor. All you need to do, for example, if you have a child goes to see a doctor and he has a high fever, is for him to do maybe RDT for malaria to see that what that person has is malaria. But because he is an health insurance patient and insurance is paying, he will give him anti-malaria, he will give him antibiotic, he will give him pain reliever, he will give him blood tonic, deworm him. So you see somebody living with 15 to 16 drugs prescribed by a doctor. This voluminous polypharmacy that happens in the health insurance space is actually a very good recipe for wastage in the health insurance ecosystem. And rational use of drugs is one of the most effective ways of saving cost as far as health insurance is concerned. So this is a study I found that really talks about, you know, the economics of quality. It says the more you improve quality, the more you decrease waste, and the more you increase productivity and therefore decrease cost. So quality care doesn't need to be cheap, but in the long run, it is cheaper because once you provide good enough quality care, the system and the patient and individuals, do not come back. Patient may not likely to come back as a result of that service you have provided. So therefore you have saved cost. And so there is direct correlation between quality of care and improvement in productivity and reduction in the cost of care and cost of healthcare services. So I'm just trying to here to link linking quality to health insurance. And so if you look at the box by the left that talks about the coverage box, our focus mostly is to increase the number of people covered by health insurance, to improve the benefit package that we provide to these people, and to get more money for this healthcare. But in the long and short run, quality is missing in this link. And so we must ask ourselves, why is that deliberate effort by stakeholders to ensure that along the entire aspect of this box, either as you are mobilizing resources, or as you are providing health insurance coverage to cover people, or as you are providing the services, you are ensuring that good enough quality healthcare services is provided. Because it's only when quality healthcare is provided that you can achieve the health system goals, which are mentioned in this other thing, which really talks about health gain and equity in health, and then financial protection and equity in finance, and then the health system become more responsive to the needs of our patients and enrollees, as I generally call them. Yes, next slide is talking why quality matter.
Dr. Krafia, over time, please.
Okay, please, in the next 2 minutes, I'll finish. So why quality matter? It is the right thing to do for your clients. It helps to retain clients, and it matters for reputation. And it could matter for reimbursement in the future. It makes quality care seamless and easy. And then I got this from the Lancet Global Health Commission on High Quality Systems in the SDG era. And it talks really, this is a very important report that every clinician should read. It talks about the 8 consequences of quality. It says poor quality health system results in more than 8 million deaths per year in lower middle income countries, leading to economic welfare loss of $6 trillion. So, and this report also showed that people die more from lack of quality care than from lack of access to care. In fact, people who have access to care, also, depending on the locations and the areas where they receive services, they get worse services than when they go to the hospitals. So that report really was a very important study that really highlighted the consequences of lack of quality care, and people should try and read that report. The report also highlighted what needs to be done, as far as quality care is concerned, and to also show that people can be especially vulnerable to poor quality care on the basis of particulars. This is important. So there are individuals who are called vulnerable points for quality, for lack of quality care. Somebody who has, for example, stigmatized diseases like HIV and AIDS, for example, when they come, they lose that focus. The patients, the doctors don't see them, or people that are from vulnerable groups, people find difficult to reach the hospitals. So that is also a very important list. So these are the steps to strengthen quality. I say you build a culture of quality, involve all stakeholders, have sound management in place, and involve everyone. And then make sure that you change the culture of lack of quality that we have. Be focused on quality and cost and the customer. And so the time that we see patient as patient is gradually getting over. Patients are becoming customers with the advent of health insurance because they pay you your salaries, they pay you the money that you use to provide those drugs, they pay for, so by their capitation, their fee for service that you are getting, these people are customers to you. Of course, ensure that you take a process improvement approach, continuously improve quality, and then raise the stakes as you improve. And so these are the final recommendations I want to say. Improving quality should be a core component of UHC. Equity should drive quality. Health system leaders need to govern for quality by adopting a shared vision for quality improvement across all levels. Redesign service delivery with outcomes in mind, For our state health insurance agencies, please go back and think of how you can really tie outcomes, to your payment system, tie performance to your payment system, strengthen PSC as a bedrock of health system, ensure competency in educational system, and hold the system accountable. If you improve quality, you see improvement. This is a classical example of before and after when it comes to quality. And lastly, I want to say quality is never an accident. It is always the result of high intention, sincere effort, intelligent direction, skillful execution, and the wise choice of many alternatives by William Foster. Thank you so much for listening to me.
Great. Thank you very much for that detailed presentation and for linking quality to health insurance, because I mean, that's really important. It's not enough for people to have insurance. It's more important for them to be able, for all of us to be able to access quality healthcare as Nigerians. So, I mean, you touched on so many important things that I hope we will be able to get into. I hope we'll have the time for the discussion. You touched on patient-centered care. That's really important. I mean, yes, patients need to be seen as the clients, as customers, so that we can truly improve quality of care and continue to improve processes. You touched on continuity. I think that's important. And hopefully we can talk on that. Patients, staying on health insurance, not just being on health insurance for 1 year and then afterwards you can't afford it or something, or there's recalibration, which we will get to. So yeah, the misuse, abuse, and wastage, absolutely. I mean, there's a lot in essence that you spoke about. Several people have asked for your presentation slides. Once you permit, we will share it to the participants. So Dr. Coffey is nodding. I take that as consent in principle.
Yeah, sure, you can share.
Great, thank you. Okay, please, if you have comments, keep dropping them in the chat box. If you have questions, use the Q&A and we will get to your questions during the panel sessions. Thank you so much. So we're going to move on to our next presentation before we start the panel session. And then we have Mrs. Mercy Ogu, who is going to be talking to us about Patient Bill of Rights. She is the Deputy Director, Consumer Education, the Federal Competition and Consumer Protection Commission. As a background and introduction, she holds a Bachelor of Arts degree from the University of Calabar, Cross River State, and has a master's degree in public administration from the University of Lagos. She worked as a public relations officer with Nigeria Airways, then as industrial relations officer with the CNC Construction Company Limited, Lagos. Ms. Ogu also spent some time with Nigeria Export Processing Zones Authority as a public relations protocol officer, and later a senior investment officer. She joined the Consumer Protection Council as a principal consumer education officer and is now a deputy director, consumer education, running the day-to-day operations of the Consumer Education Department of the Federal Competition and Consumer Protection Commission. She is a member of the Nigerian Institute of Public Relations. Thank you. Welcome once again. You can go ahead and share your presentation.
Thank you. So, sorry. Let me look for a place to share. Okay, can I share my screen now?
Yes, you can.
Oh. Just 1 second, please.
Want us to share on our end.
Let me try. If I can't get it, then you help me.
If you would see more, like 3 dots at the bottom next to the camera icon. If you click on that, yes, see share screen.
Okay.
Okay, great.
So that I can't see my presentation, I think that I can share screen now, but to get to my presentation. Okay, I'm coming. Right. Sorry, 1 second, let me get there. Can anybody see anything? No?
We can see your screen, but not the presentation yet.
All right, so just give me a minute, please.
Yeah, Okay.
Oh. But I sent it to you. I don't know that you can help me share too. Let me try this. If I
If you
can't,
prefer, we can. Okay.
if I can't get it from here, then you help me share. Please, can you help me share? I'm having issue here.
Okay, no problem.
Thank you. So, where are we now? I should stop sharing so that I can
Yes,
share.
I'm just gonna, yes,
Right.
yes, please. Thank you.
Sorry about the delay.
No, it's okay.
Okay, I can see my screen now. Hello, good morning, everyone. Sorry for this. Let me see. I'm not even seeing my. Okay, thank you so much. Good morning. I was listening to Dr. Kofi Abubakar. He was talking about quality, and it's all about what we're going to talk about today, because it's the passion my EVC had about having quality service delivery that gave birth to this patient bill of rights. And it's a good thing we're all talking about cultivating quality culture for Nigerians, because even up until now we are running a campaign in a FCCPC. The campaign is "Quality is your right." #demand and insist. So we're going to talk about this. PBR is how we can have a quality service delivery in the healthcare sector. And the PBR now is, we try as much as possible to reach out to people, to organizations, to anybody to help us spread this news. Because now we are talking about patients not knowing their rights, because we believe that if they know their rights, they will demand and insist. So on this table of content are things I'm going to talk about on this PBR. First is the introduction, where we will tell you who we are, FCCPC, and the vision statement we have for setting up the PBR. Then we can now discuss the PBR. Okay, it's in detail, but I'm going to be very brief. And then we'll look at the healthcare value chain, because the PBR is not only for hospitals, it concerns all the people within the healthcare value chain. We'll look at the objectives of the PBR, we'll look at the patient's responsibility, and some of the challenges that FCCPC has been experiencing since this PBR was vetted, and the way we're handling these challenges, and our vision concerning the patient bill of rights. Let me get the next slide. Next slide, please. Okay, so for us, Federal Competition and Consumer Protection, foremost Competition and Consumer Protection Authority in Nigeria. And FCCPC was established under the FCCPC Act 2018. And among our mandates, we have so much mandate. On the competition side, we try to make sure that the market is a fair playing ground for all businesses. You have opportunity to France at dominant positions in the marketplace, and then we protect consumers. That's a part of our functions, is to protect the interests of the consumers and make sure that consumers have speedy redress when they are aggrieved about product or services, not only the service sector, even products. We also, because of the safety of consumers, because our main concern is that for whatever service or product a consumer is buying or using, it should be safe. So we seek ways to remove hazardous products from the market, some standard products, anything we know that will be harmful to the consumers. Our mandate and our main concern is the consumer, and we try as much as possible to protect them in all ramifications. Can we go to the next slide, please? Okay, we're still talking about the PBR. We all know, even when doctor was present, you know that within Nigeria, I saw him showing different captions of this is how this is service, different aspects. You know that Nigeria, for quality healthcare, their rights are being violated in the healthcare services. We know that. Doctor was even saying that he just went there and pretended that he's a patient, and he saw how long it took him to even get attended. Somebody was even telling him, you're even lucky you attended to someone, even come the next day, they have not even been attended to. So that's how you see, that's how you know what patients, consumers. For me, you see me as I'm presenting these things, I'll be talking more on consumer, because our interest is the consumer, and consumer is anybody that uses money to buy a product or a service. So oftentimes I'll be interchanging the word patient with consumer and all that. I'm still talking about the same thing. So you can see what the doctors did. He just pretended that he's a patient and he is a doctor, and he went through all that. So, and it was even told that you are even lucky that you even got it that day. So these are the things we experience in Nigeria, and these are the kind of passion that drove my chief executive. You know, he's a very proactive person. When he came on board, his interest is to make sure that we cultivate quality culture in Nigeria. And when he came on board and these things are not there, he now said, no, something has to be done. And this patient bill of rights was realized. You know, we have to look for policies, some legislation and all that, put them together before we're able to get that patient bill. Some of them is even under the making sure, if you check the 1999 Constitution, there is a patient quality healthcare service there, rights to have access to quality healthcare. In the National Health Act 2014, you find out that in all our legislations and documents here and there, if you pick them here and there, they all talk about how we can get this quality healthcare service delivery. BC came and saw this. He said, no, we have to put them together as a document and make sure that we bring it out, especially for the patients to know that they have rights in this healthcare service delivery sector. Please let me look at this next slide. Okay, it's our vision statement. PBR, that is the patient bill of rights, is consumer-centered, customer-centered. So all we're trying to do is to empower patients, consumers, to take an active role in making their own decisions when it comes to healthcare service. So it's customer-centered, and we're shifting that focus to see that, oh, when you come to the hospital, is the doctor or the whoever that is there is the master. No, you as a consumer have a right there, and we are always asking them to. We try to let them know their rights and try to tell them to demand and insist on this right. So our vision statement is to ensure customer centricity in the healthcare sector by moving their focus now to the consumers themselves, empowering them to take an active role in making their own decisions. Next slide. Next slide, please. Can you hear me? Next slide. Okay. So we want to talk about the patient bill of rights. Yes. So, yeah, the patient bill of rights, like I said, was a collaboration. You know, it wasn't an FCCPC thing alone. We even have to do some comparative studies with other clients, like other international, other countries, you know, see how their own is being operated. The NMA, the Nigerian Medical Association, we are there. Before we commence, we have to bring them into this. We had a series of meetings and deliberations to be able to formulate an acceptable guide that can help between the interaction between the patients and the medical doctors and other healthcare, to other people also in the healthcare value chain. It's not only hospital now. And this guide is this patient bill of rights. I think the stakeholders within the healthcare facility, they all made input into this. It wasn't like FCCPC brought us something to impose. It was a collaboration, and we agreed that this is the best way we have to do this so that everybody can enjoy quality healthcare service in Nigeria. Let me look at the next slide, please. Next slide. Okay. Yeah, I try to bring I hope you are hearing me. I hope everybody is hearing me.
Yes, we can hear you.
Hello, am I breaking? Okay, you're hearing, thanks. So I try to bring the launch of this PBR into this presentation because it shows how important my EVC attached to it and the vice president. This PBR was launched at the banquet hall of the State House by the vice president himself, and it's because of how important this is, how important my EVC and the country is taking all these shabby treatments that the patients are getting. So we launched it at the patient bill of rights. If you look down, you some of my EVC's comments during that when the launch was being made. It's all about the dignity in healthcare, and the reason why he is so passionate about it is that when you are sick, you are at the weakest point of your life. The patient, when you are sick, you are so vulnerable. You need assistance, you need help. And to be exploited and abused at this time of need it can be very devastating, even to the patient themselves and also their family. So doctor was talking about quality. I said, oh, thank God. It's like we're all talking together. It's all about how do we get quality service delivery in the healthcare sector. So the essence of the POBR is, this is the weakest point of this patient. He cannot help himself. And if he's being exploited, it's like breaking him down, making him. So the best thing is that what do we do to help at this time? And another thing about it is that, society is also, the kind of treatment somebody gets at this time of his life, at this time of need, determines also how your society regards you. How a society takes its own people. I know that America, no way, they don't joke with their citizens. In Nigeria, you treat people anyhow. So the kind of treatment you get, especially at this time, determines the way your society holds you, whether they have dignity for you or for the human beings or humanity at this time. So that's why you see from so many speeches and all the things we heard, we find out that we are not treating our people well, and we have to change. We really have to change, because our people are what makes our society, and the earlier we have respect for them, the better. Please go to the next slide.
Please, you have 2 minutes, Ma.
Yeah, I've not even got. Whoa.
That's why I'm letting you know.
No, please. No, you have to give me some time. No, I know you give me at least half of the time you gave doctor, please. Half. I know he took a lot of time. Please.
I'm not cutting you off. I'm just letting you know.
All right. No, not 2 minutes. Make it 5. Make it 5, please. So what am I trying to say? I want to read this because it's the vice president. No. Go to the next one. So I'll be rushing. I want to. I've talked about it to look at, and because I'm very passionate about it. Let's check the next slide since you are rushing me. Hello, move to my next slide. Let me see. You can't hear me.
I think there's a delay on your end. It's currently on vice president. So maybe wait a few seconds so you can catch up.
Okay, different legislation, peace and peace here. That's what all this are saying. We have the freedom of speech and all that. This is what I want to say. So if Patient Bill of Rights is not from one particular, we pick legislation here. I have said that before. So I want to say this. This is the Vice President's speech when it was being launched. He said in his speech that human rights and respect for human dignity as one can tell a great deal about how a country values its citizens from its healthcare institution. So this is the responsibility of not only healthcare practitioners, but the entire healthcare value chain. So that was what I was trying to say. The Vice President also reiterated this thing, that it depends on how you have respect and dignity for humanity that determines how you treat them. So that's where all this Patient Bill of Rights came out. Let's rush. Since you are rushing, let me go to other areas. Please, the next slide. Okay, like I said before, the Patient Bill of Rights is not only for hospitals alone. All the healthcare value chain, I try to list some of them here. You see them, the pharmaceutical industries and all that. They are all involved. Let's go to, they are all involved. This PBR applies to them too. Go to the next slide. Okay, I'm just trying to get a pictorial view of the, go to the next slide. These are the healthcare value chain. Next slide, please. Patient rights. Okay, we developed this patient right with the expectation that also the hospitals, healthcare service, the people will support it. The objective of this healthcare is for healthcare services, both the hospital and the patient themselves, to know their rights and responsibilities. And for the healthcare institutions also to try to talk about the rights of the patients here. And part of the thing that the healthcare service will expect them to help us do is also to help the patients to understand this right in a language that they can understand. We have different categories of people. We have the literate, we have a tribe, we have religion. Just the healthcare, there a lot is upon the healthcare service delivery sector to make these patients to understand their rights. These are parts of what is listed there are the rights of the patients. I might not go through them, but I think doctor was talking about affordability and all that. One right I would like them to know that patients have a right to receive urgent, immediate, and sufficient in an event of an emergency, whether he can afford it, whether he cannot afford it, because it's an that time. So you can scroll after. I will let you to have these slides and then go through it. I might not be able to, but I'm pointing this out because when we're looking at affordability, some people will enter and they say, where is the money? Who is going to deposit? Please, at that period of emergency, intervene. That's what we're telling the healthcare facilities. These are part of the, okay. Now, they also have responsibilities. Part of the responsibilities of patients is that important aspect I want to point out. Go to the next slide on the responsibilities. You can get it when you get the slide, you can go through. Go to the next slide. Okay, yes, this is an important responsibility. We are telling patients that in as much as you are okay, we expect the healthcare staff. You know, there was a time I went for sensitization in Kotangora, and the healthcare staff were telling me these patients are very rude. They even give us bodily injury and all that. No. Because we are protecting your right, you have a responsibility also to respect the healthcare staff, because they too are working under a very stressful condition. Their circumstances they are working is also stressful. So you as a person should treat them with respect and not be violent or abuse them sexually, verbal abuse, racial, to talk to them rudely at that time. It is not accepted. So go to the next slide. Let me not rush. I might not be able to go through. Go to the next slide. It continues like that. The responsibility. Let's go to the next slide. You can look at it after because I'm going to drop this.
We don't want you to miss the important points. Please Johnny, but that point.
Okay, now the challenge, please let me talk about the challenges, because that's why I'm here and I want to let it know. So, and I'm happy that we have doctors here. Part of the challenges we're experiencing is that the domestication of this patient bill of rights. At the launch, all the doctors, the ministers, all of them were there. And the vice president charged them because we cannot reach out to these patients one-on-one. Please domesticate it, place it strategically in your hospital, in your facility, so that patients will come and know, these are my rights and these are my challenges. But the hospitals are not doing that. When we observe that, my EVC has to engage all the doctors all over again, asking for that. But I found out that I don't know why hospital, doctor was talking about quality service. Please, we have the patient bill of rights. Please domesticate it. Place it strategically. If you want, please, after this, the doctors that are here, let me get your contact. I know that when the patients know their rights, like our demand and insist campaign, when they see that this is their right and they're not getting it, they will demand for it. And when they demand for it, they will receive it. And then we will have quality service delivery that all of us are sitting down here to see how we can do. Please let us let the patients know our right. FCCPC cannot do it alone. It is everybody's business. In your own facility, please help us. I will be so happy that some people will just send a text or give me their address. Very happy to send the patient bill of rights to you for you to display it. And they have if you do that, FCCPC will even send you a letter commending you for doing that. Please, that's my major objective. If that is the only thing I achieved today, it's okay. Please help us spread the news. Doctors, hospital, healthcare facilities, please, we want to domesticate patient bill of rights. Help us to do this. Thank you. I couldn't go through because it's so long, but you can have this after. Since they're telling me it's my time. Thank you so much. And we're still doing more. I'm still talking about domestication of the PBR. We need help to do that. And I thank you for giving us this platform again to talk to people, for them to even know their rights. Even though I couldn't go through it, you can have this slide after this. This is another way of disseminating the information. Thank you so much. My slides are still behind, but it's okay. I passed my message. We want to domesticate patient bill of rights. Please help us do that so that patients will know their rights. The hospitals also will know their obligations, their responsibilities. Service providers will know their responsibilities. Patients will know that. We even have, there is this compendium that we have, where if you ask for it, I will still send. It's very comprehensive. In that compendium, you see the patient's right, you see the patient's responsibility, you see the patient's, the service provider responsibilities too. Please help us spread this news. Thank you.
Thank you very much, Ma. We've heard your plea, and that's why we're here, to help drive the conversation forward and to help improve knowledge and awareness on the patient's bill of rights. And thank you for your.
No, yes, I'm saying that anybody that needs the slide too, I can send to them so that they can have time to go through it.
Okay, I think we can just share to the database. People who signed up for the webinar would do an email blast. So you can also send the patient bill of rights. We would share as well along with the slides.
Thank you very much. So Amaze, did I get your name? So you give me where I can send it to after this. So
no problem. We will let you know afterwards.
All right.
Thank you very much. Thank you for your presentation. Even though we had to rush you through it, we want to get to the actual conversation. We have people on the panel who can contribute to this conversation and want to get to that quickly. But you touched on important things: the domestication of the patient's bill of rights and your advocacy to the doctors in the house and the health facilities to help domesticate, help increase visibility, knowledge, and awareness. And we are happy to support that process. And then you also mentioned something on the rights to receive urgent and immediate care in terms of emergency. I think that's something that would be interesting to the general public and will probably cause a heated conversation between the health facilities and the general public. Thank you very much. So without much ado, we would like to move into things, use the Q&A box and we will get to them. So on our panel, we have Dr. Rock Amego. I hope you can hear me. It's saying my internet is, I hope you can hear me. On the panel, we have Dr. Rock Amego. He is the Director General of Edo State's Health Insurance Commission. We also have Barrister Ngozi Nduka Uba, who is the former Executive Secretary, Health and Managed Care Association of Nigeria, HMCAN. We have Ms. Tonya Deshola. She's the Executive Director, Sickle Cell Advocacy and Management Initiative, SAMI. We have representing Dr. Emanuela Zamba. We have Dr. Serrano. Sorry, 1 second. And then we have Funke Awayemi, who is the Treasurer, World Health Committee for Igbogo and Bayeko LCDA in Lagos State. Thank you very much, everyone, for taking out the time to be here. We appreciate your presence. Okay, so I think that we would like to start with Dr. Curfew. And again, thank you for the presentations. Please, everyone, drop your questions in the Q&A box. Dr. Curfew, you spoke a lot about quality healthcare, and you touched on the role of health insurance. You also spoke about the NHIA Act, which actually says that the authority shall ensure that health insurance is mandatory for every Nigerian and legal resident. So the first question to you is, how will this be achieved? I know you mentioned something about the Basic Healthcare Provision Fund catering to 83 million Nigerians. It'd be nice to know what percentage of that 83 million is currently covered, how we intend to achieve mandatory health insurance for everyone.
Okay, thank you very much, Egobon. The signed some few months ago, like 2 months ago, and currently the scheme has started developing what we call a roadmap for the implementation of that act. This roadmap will also involve translating the act into an operational guideline that will ensure that all the various components and sub-components of the law are translated into implementable activities. So that process is currently ongoing, and that involves all the legislation or the policies, the advocacies that need to be done to ensure that the mandatoriness component of the law gets enforced and enshrined in our day-to-day affairs as a country. Yeah. Thank you.
Thank you. So for the vulnerable populations, there's vulnerable, there's the indigent. Is there a difference between these two, and how are we ensuring that they are aware of this provision and accessing?
Okay, so for the vulnerable and indigent, I don't think there's any much difference. It's just a degree of vulnerability. So indigence in terms of financial hardship. When you are poor, for example, financially, you are vulnerable because of lack of resources or lack of money. We say you are vulnerable as an indigent person, you are vulnerable because, so financial difficulty makes you indigent and then you become vulnerable. So it's just a degree of vulnerability. Regarding the, how are they going to be aware? So the good thing is that we're not starting on a fresh slate. The country has already developed a very comprehensive database of in the social protection space. The National Social, they call it NASCO, National Social Register. That's a very comprehensive register that has about 45 million vulnerable groups currently well documented in the country with their addresses and everything. So we have something to start with, yeah.
Great, thank you very much. Okay, so we'll start with Lagos State. Dr. Serrano, please. what do you find to be the challenge in improving uptake of health insurance amongst residents in your state? And particularly the vulnerable people as well. I mean, vulnerable people are important to us at NSF. I mean, one of our priority areas is supporting vulnerable populations. And yes, people who are covered by work or have the means to pay, there's need to improve insurance amongst them. However, we're particular about the vulnerable populations. Generally, what are your challenges in improving insurance coverage? And then specifically for the vulnerable groups, how do we intend to reach them? And the informal sector.
Yes, thank you very much. Thank you for giving me the opportunity to appear on this panel discussion. So with respect to uptake of health insurance schemes, so there are generally two broad reasons why people would not generally get themselves involved in health insurance as a whole. So you have willingness to pay and ability to pay. So you have willingness to pay. These are people that really and truly can't afford to pay for the health insurance, but just refuse to pay for different reasons. So a simple example is we're a government entity, and some people may just not believe that government entities work. So that on its own is a problem. They also have the perceptions of insurance as a whole. People have been burnt with general insurance, so they have this general perception that insurance is a problem, and anything in insurance, you never get value for money. So that's for the aspect of willingness to pay. Then for ability to pay, they have a group of people that may be interested in paying, but due to the economic situation, they are unable to pay. So in terms of addressing those people that are unable to pay, what we've tried to do is try and educate them and sensitize them to make certain sacrifices, that in terms of it's cheaper to pay for health insurance than to get to the hospital to pay cash. So that's some form of advocacy that has been done on our own side. Then the other thing we also do is that some health insurance policies require annual payments. For us, what we've done is we've tried to make it instrumental payments, whereby people can pay, instead of paying the annual premium, they pay either a quarterly premium, a semi-annual premium, or in some instances, monthly premium, to break it down to people. So, because if you look at it this way, a typical laborer earns between 3,000 to 5,000 naira per day. So, but if he's able to set aside one of the 1,000 nairas in a single month, he's able to cover himself. And if it's 3,000 naira per month, he'll cover himself and his family. So those are some of the things with respect to update. And for those that absolutely cannot pay for any reason, even if the premium by 500 naira, the law actually makes provision for what we call the equity fund, such that those vulnerable and poor, the Lagos State government will willingly pay for them such that they can have access to care. So those are some of the issues with respect to poor and vulnerable. For those that have the ability to pay, but just refuse to pay, it's education and regulation that will get those people on board the scheme. Thank you.
Thank you very much. Dr. Serrano is the head of operations for LASHMA, Lagos State Health Management Authority. Thank you. Dr. Rock Amego, over to you. Are the challenges the same in Edo State in increasing coverage of health insurance, and what is being done to ensure that everyone is reached? Thank you.
Yeah, good morning, Ameze. Good morning, NSSF team, and some of my colleagues that are here. I think I saw earlier my commissioner here, so I'd like to acknowledge your presence. Thank you for joining. Good morning, Professor Okoria. The dynamics of health insurance are basically the same across youth board, in the states and in the federation. A lot of people lack trust in the system, and so just like my colleague said from Lagos State, when government projects program come up, people advance towards government projects because over time they've been burnt and all that. But communication is key. All right. Sensitization for us in those states, the moving goalpost. All right, it never ends. In our personal life, in our business life, in our day-to-day life, we try to communicate on health insurance and how people to get into the scheme. All right. The vulnerable in our state, we have tried to do more for them. We have tried to set up the equity fund. We haven't tried to set up something they call a top-up plan, all right, so that people who cannot pay and those who are between the spectrum, between vulnerable and those can pay, they can come up with certain amount of money, so that however small, they are participating in their healthcare. And this can also prompt them to use the healthcare facilities and also give us feedback where challenges might occur. A lot of schemes in the country, what we found and what we realize is that their premiums sometimes are very low, and so sustainability is an issue for them. The good thing about those states, what we did is that we priced our premium using Ernst & Young, and so quality of service, because of the inflation that has been up in the past 2 years, the dollar inflation, we've been able to ensure quality of service because our premium and inflation was calculated in it. So basically for us, sustainability is key and retention rate is key. So we try to give quality of service as much as possible. We have something in the scheme what we call a positive enrollee experience, where the desk officer doubles as the enrollee of experience officers to make sure that the journey map with the patient when they get through the facility is a one-stop shop, whether it's laboratory investigation, clinical investigation. However, that one-stop shop can give them, access to care and quality care. We did a research sometime in the past that showed us that, perceived and observed gaps. People sometimes not, when they get to the facility, the transient time between seeing a healthcare provider and a doctor or a nurse or a CHO, as the case may be, if it's very long, those people are not going to come back. All right. Somebody, I give you an anecdote, I give you a situation. Sometime in the past, especially if you're outside the country, it's very difficult to see a medical doctor. And sometimes you see a nurse and then she greets you very warmly. Hi, how are you, darling? How is it going? It gives you a pat on the shoulder, rubs you. And you're going home and the nurse is giving you paracetamol. And then you're fine, you're good. It just goes to show that whoever controls the mind controls, everything. So health is not just necessarily the absence of disease, but a state of complete physical, mental, and social well-being. And so because of that, we make sure that all our enrollees have a positive enrollee experience when they get to the facility. The desk officers acts as double up as an enrollee positive experience officer. And so we have a higher retention rate because quality of care is given, communication is given. And so we try to ameliorate the gap between the healthcare providers and the enrollees, because we know that the ratio now in the country is very high, doctor to patient ratio. And so doing that sort of gives us a balance, short-term and medium-term goal to address that before manpower can improve in our system.
Great, thank you. I mean, it seems like you are preempting some of my questions because during our Twitter Spaces conversation on Tuesday, there was a lot of talk about trust in government, and I think we'll get into that conversation later. But you also just touched on, and it's great to see the way that both states are already thinking of how to make health insurance flexible and more accessible to everyone, and that's really great. The top-up plan, the scheduled payments, that's fantastic. But you touched on sustainability. So you more or less have told us, because again, during the conversation, there were comments on questions around sustainability of state health insurance schemes. And you have touched on how Edo State is ensuring that your scheme is sustainable. And I'd like for Dr. Serrano to maybe chip in there. Do you have any comments? How is Lagos State ensuring sustainability of the state health insurance scheme? Because like I said, some people think that that's not the model that works for Nigeria. This state health insurance plans and the basic healthcare provision fund and mandatory health insurance that we're trying to drive. Dr. Serrano, please.
Yes, thank you very much. So now sustainability, every health insurance program, plan, whatever you may want to call it, needs to be sustainable because trust is a major thing. You can't expect people to pay for this year and 9 months down the line, the scheme collapses. So to ensure sustainability, like Edo State, we also included the services of an actuary to determine what the appropriate pricing will be, what the appropriate tariffs should be, and the scope of services. There's no point charging 1,000 naira to ensure that everybody can afford it and promising CT scan that is extremely expensive. If you approach it that way, the scheme will round up in 6 months. So those are some sort of things. So we put in processes. So for us in Lagos State, we actually have an in-house actuary that constantly evaluates the scheme. Are we on the, I don't want to call it profits, but are we on the green side of things? Or are we having financial issues? So that continuous checking and tracking of our financials is actually important for sustainability of the scheme. And of course, in ensuring sustainability, you also have to ensure that people are able to pay for it and ease of payment. So you have payment issues whereby payment points are easily accessible, easily available, so people can pay at different points. So, but it's important. Sustainability is a major thing. And I'll say appropriate pricing, appropriate benefit design, and having appropriate monitoring and evaluation supports sustainability. Thank you.
Great, thank you. I think I'm going to go back to Dr. Curfey. So how is the agency looking to innovatively fund health in a sustainable manner that the citizens will, in quotes, approve of? Again, because we have spoken about trust and the lack of trust in the government. So there's all sorts of new direction that we're looking to go, the sugar tax, telco tax, but citizens don't trust the government. So one, how, can you talk more on the innovation for health financing and how we intend to build trust and ensure grassroots consultation? Because there was also talk about poor grassroots consultation. Thank you.
Okay, thank you. I think the first question should be, how is the country trying to innovatively finance healthcare? Not how is the agency trying to. So how is Nigeria trying to innovate? And I think that's, and the first and most important aspect here is the political will and the commitment of the government of the day to finance healthcare. That itself is the first and number one important thing. And I'm happy to say this government has really shown that extra commitment to financing healthcare. The signing of the Health Insurance Act, the Basic Healthcare Provision Fund disbursement that has been going on is a classical commitment on the part of the government. And the new act provides for what we call Special Intervention Fund to finance healthcare. And the law says this Special Intervention Fund will be budgeted for and provided by the government to cover these vulnerable groups. It also opens up the space for other sources of financing healthcare within the context of the law. So the SSB tax that you mentioned, the sugar sweetening beverages that the government has started collecting, which I want to say is a very important step, but the percentage the government is collecting, I think, should be higher, because a tax of that nature should be a tax to discourage people from consuming those services. So that kind of money can be earmarked for health. The government can also look at a form of health insurance levy, where we can see how we can. Well, of course, the previous law, we made attempt for the telecom tax. So where we can get some funding, or what we call 1 kobo per second bill, 1 kobo per second to finance health insurance, but that did not scale through. But that does not mean the door has been closed for further discussion towards ensuring the telecom sector contributes to the health sector, as done in other countries. So of course, there are a lot of other these things. But one important angle that I also want to say is that the health sector needs to prove to the world and to the country that it has, one, the capacity to absorb that fund. The Basic Healthcare Provision Fund has been disbursed across the various states, and if you look at the utilization level for these healthcare services, it's still low. So states need to aggressively pursue massive awareness creation, for people to know of the BSCPF and begin to access healthcare services. And two, the accountability needs to be shown to be openly there and transparently there, and if you show accountability, it's a recipe for asking for more, so that is also very important. And lastly, I also want to say the resources we have in the NHIS, the government needs to give us the capacity to invest these resources to actually use that investment proceeds to cover more vulnerable groups in the country. Thank you.
Thank you, Dr. Curfey. Are you familiar with the term, you want to steal my joy? Nigerians, I mean, you're talking about increasing sugar and sweetened beverage tax. When people are complaining that you're taxing them at all, the small joy they have in Nigeria, you want to collect.
Yeah, they can take orange juice, they can take water, they can take healthier options are available. I'm not just this on a lighter note. It's on a lighter note actually.
I'm with you, and they'll tell you how the healthier options happen to be. I'm on your page, but I'm just speaking for the public. The healthier options are also expensive. How much is orange? How much is a bottle of ice? But right, yes, thank you. Okay, so you touched on utilization, and I'm going to get to that again at some point. Utilization of the Basic Healthcare Provision Fund. But I think that, speaking of innovation, during our conversation again on Tuesday, we had one of our speakers, Mr. Nonso Oprum, who is the founder of SosoCare. And SosoCare provides an innovative solution to health finance and health insurance through recycling, where people pay for health insurance by recycling materials. And they mentioned being able to support at least 7,000 people in one community alone. I think that is pretty impressive. I think that's something that should be looked into. And maybe there should be some collaboration and see if we can scale that, or, but it's interesting that people also have other solutions for innovative ways to improve access and coverage of health insurance. So just mentioning that. I will come to Ms. Toyin Adeshola. You were part of the conversation we had on Tuesday, and you spoke about your work providing health insurance to sickle cell warriors and the challenges with that. So you should share a little bit on what you do and what the challenges are, now that we have people that can possibly respond or do something about this challenge.
One of the major things I see is that Nigeria doesn't recognize that we have the highest number of people with sickle cell in the world. And that is a huge population when it comes to healthcare and healthcare management. And that's why we took it upon ourselves to try and manage and support the health of people with sickle cell. Because we found out that, especially when they are young, we found out there's a lot of parent abandonment, neglect, frustration, because they can't access adequate healthcare for their children. And you find them sometimes taking advice, going to traditional medicine, people who do worse. And one of the things we did was to try and create a framework through our monthly free clinic, where we realized that even after the clinic, yes, we give them free clinic, free drugs, free doctor's consultation, but post clinic, which is just once a month, there are issues of crises occurring, because crisis occurs ridiculous hours of the night. It doesn't announce itself. And you have parents being frustrated and anxious, and then they have to think about taking the child to the hospital. And one of the challenges they face, of course, is finance in trying to get the child to the hospital. So we had to step in some form. We started by providing medical support, but we found out that, especially with what we call repeat beneficiaries, it was becoming a burden on us to just continuously pay for these medical bills. And that's why we thought, okay, let's put them on health insurance. And we went through the process of trying to put them on various health insurance. In fact, we've changed health insurance more than at least 5 times because of various issues, which I'm going to talk about. And when we finally got there, we had various issues of you start up with their plan, you register, then over a year, you have what you call recalibration. And sometimes it's recalibrated to at least 100% with these private HMOs. Now, when we talk about the public ones don't really recognize the number of times these people go to hospital. So you have limited hospital admissions, which for a sickle cell warrior, that is not enough. And the other things are not really covered. So we looked at the private one, but there's the issue of recalibration. Then there's also the issue of third party. If you can't do recalibration, you do third party, where you just give them a certain amount of money. That's the HMOs. Maybe, okay, say like 2 million, and that will cover whatever number of patients. And whenever the money finishes, that's the end of it. But this also includes their own administrative bill, administrative fees and other things. So it was not really beneficial to us because sometimes one patient can almost take half of that. So we realized that one of the things we saw is that there was lack of communications between the agents, call agents, and the patient, because by the time you get to the hospital will call the HMO. There's this delay, and I'll call it, there's some form of, I like call it stigmatization, compared to someone who is not on HMO that has the actual money. There's a tendency to answer you first if you're paying direct. There's a tendency for it to drag when you're doing on HMO. You sometimes wait up to 30 minutes between, oh, they've not sent in approval and all that stuff. So there's need for more education. Sometimes you will have situations where hospitals take on the role, like Dr. Kofi said, people just pile on things. And if the patient is not educated enough, for me, I've seen situations like that personally, but because of my knowledge, I've been able to curb it, where they just pile on MRI, they pile on this, pile on that. And I ask questions, what's it for? Why are you giving, what is it necessary? And that's been able to cut down, on it, because at the end of the day, if you don't cut down on it personally, you have gone over your limits, and then your health insurance has become a 6-month affair instead of a 1 year affair. And one of the things I realized with health and health insurance and also health management is that sometimes there's this tendency, maybe because of the pressure and of the number of people that the doctors see, there's this tendency to, from the nursing station to the doctors, to see patients as numbers, and not as human beings. I had that experience, and even the patient doctor wanted to ask what was the issue. She directed the question to the nurse, which I found strange. I'm sitting in front of you, and you're asking the nurse what's wrong with her. So, and that goes to show that lack of empathy, that lack of understanding that this is a patient, this is a person, and this person has the rights, like we have the right to speak. I always tell my beneficiaries that they should already have the right to question a treatment. It is very important, so that we don't have this abuse or misuse. And so then basically it's a challenge with trying to manage that the pre-existing condition is not recognized, not just sickle cell. You look at other people with disabilities who have other conditions that need to be managed. And when they are forming the plan, all this is not put into consideration. When you're trying to write the cost of what the person is going to pay. I know it can be higher because you have a pre-existing condition, but that is even more comfortable than not having at all. And then secondly, there needs to be education within the people who are with the hospitals themselves, because there's a lack of understanding on how to communicate the use of the HMO, how to communicate with the patient, how to communicate with the HMO themselves. And communication between all people together is also a factor involved. And finally, I think the delays should be addressed because it's a lot of issue. When somebody is going to hospital, you think that being on HMO is easier than just like Dr. Kofi was saying, spend hours. Sometimes, if you don't know anybody in that hospital, you can sit there waiting for your approval for hours if you are not careful. So because I find myself having to call somebody higher in the HMO that please deal with it. I've been sitting here for 30 minutes waiting for approval. And that's when things go. But how many of us have that access? So I think it's something that needs to be looked into. Thank you.
Great, thank you. I think you have touched on so many things, and you kind of buttressed the presentations we had on patient bill of rights, and quality of care and patient-centered care, because I mean, that's the direction the world is going into, patient-centered care, not just looking at patients as numbers and not just looking at the presenting illness, but also looking at the socioeconomic aspects of the patient so that we can actually manage them as individuals, as whole human beings, not just as diseases. So great, thank you. I think I would like to call on Barrister Ngozi as the former Executive Secretary of the Health and Managed Care Association of Nigeria, regarding the issues on pre-existing conditions and recalibration. What is your position on limited health insurance options and these challenges that are experienced by people with pre-existing conditions? Thank you.
Thank you for having me. Just like the last speaker said, when she talks about the patients with sickle cell anemia, these are pre-existing conditions. And notwithstanding the challenges they encountered over time, but she was able to find health insurance companies that were willing to take those patients for even pre-existing conditions. So I think the major issue is that of disclosure. When you go to an HMO, you tell them exactly what it is and how it is. And if they're willing to take you, why not? But when you have issues of people with pre-existing conditions going to HMOs and not disclosing, and the companies down the line, finding out that these conditions existed and they were not disclosed, I think probably that will result to some issues, because the HMOs will end up incurring more bills from the hospitals. Because if a person was, in quotes, I'm not going to say they're unhealthy, if somebody was normal, in quotes, didn't have any pre-existing conditions and had to go to the hospital when you fall ill, it's not going to be as regular as a person that has a pre-existing condition. That is one. And then secondly, if the HMO knows that there's a pre-existing condition, and of course, in the management, the hospital will also know that there's a pre-existing condition here. And they, like she said, sometimes you go to the hospital and then you spend hours, probably because the hospital was not aware that such condition was existing, because if the HMO knew, right before you even get to the hospital, they will get in touch with the hospital and say, this patient is on his or her way to the hospital. I am speaking as an enrollee, and I used to fall sick because I'm human, and I had to wait in those waiting rooms. But for somebody who has a pre-existing condition, I don't think any HMO will let you go to the hospital and stay in the waiting room for several hours, or even the hospital knowing that, oh, we have this enrollee who has a pre-existing condition, and they let you stay in the waiting room for hours, before seeing a doctor. So I think basically the major issue here is that of disclosure. Are they aware that you have a pre-existing condition when you were filling those enrollee forms or when you were taking a premium? I think basically that's very important.
Okay. Ms. Tonya, I see you smiling. I don't know if you have a follow-up, but I would ask one more question. Well, Ms. Ngozi has since Barrister Ngozi has the mic. Someone put in the Q&A box, what is the best insurance plan for people? A lot of the newer HMOs tend to offer little or no active insurance coverage. So maybe what should people look out for when they're trying to pick health insurance coverage?
Is that for me?
Yes, I think that you can just. Ms. Tonya, I will come back to you. I can see you want to say something.
Okay. I think prospective clients should be able to do a little research on their own. you know, you don't just depend on what you see on paper or on the website. I think one should actually be able to go to the HMO, go to the office and talk to the staff. And they also sample the opinions of healthcare providers and find out, how is this HMO doing? You know, do they pay for those who are on capitation, do they pay on time? Do they settle their bills on time for, you know, fee for service issues? The client, the prospective client should be able to do some research, you know. You don't just pick an HMO off maybe what you saw on the newspaper or what you saw on the website. I think you should be able to go to that HMO, have a chat, and then also sample the opinion of providers to see how well those HMOs are doing before picking a premium with them.
Okay, thank you. Mr. You can make your comments now.
Okay, I just wanted to address a few issues mentioned by Barrister Udukauba. First of all, the hospitals know, at least from our point of view, because we're a sickle cell organization, we were registered with this HMO. It is known that everybody, 90% on the bill, is living with the pre-existing conditions. And the fact that when we go, is not that when we first go, they refuse to attend. On a regular basis, you know me in this hospital. But then the communication between the HMO, when it comes to, okay, approving, let's say blood tests, approving doctor's consultation, approving X-ray, there's a period of wait when the patient has to wait for the approval to start this or to go and do this test. So that is the area I'm coming from. It's not the first point of entry when you just first go to the hospital and introduce yourself to the hospital. The hospital already knows you. And that is a challenge I see across board, because as I said, we've gone to not more than one, but I think four HMOs. And it's the same thing. We always have to call, you know, what's happening. This person hasn't been approved. You even get to a point that some hospitals say, oh, they don't do people with sickle cell, or they will say, no, their hospital admission only allows for 3 days, whereas your plan allows for more than that, or it doesn't allow for feeding. You know, there are different discrepancies. That's why I said sometimes some of these hospitals chosen, I don't know whether they are not properly investigated or what, but there's that miscommunication and lack of education among the three sectors. Thank you.
Thank you. If any of Dr. Rock, Dr. Serrano, if anybody wants to comment on that, please just put your hand up and we will take your comments. Okay, Dr. Serrano, please go.
Yeah, so speaking from a social health insurance aspect, so for us in the state social health insurance scheme, let me speak for Lagos specifically. We don't consider pre-existing conditions. So that means we always tell our clients, come as you are. And that has had some impact on our scheme, but we accept people as they are. So now speaking with respect to sickle cell as an entity, so for us under the scheme, we cover three components, or I'll say that are important to sickle cell care. So you have the pain management, blood transfusion, of course, also cover admission up to 15 days. And we recently introduced hydroxyurea as part of our medications that are available to sickle cell patients. But to buttress the Barrister Ngozi Nduakaba, it's important that you do your research before you enter and dabble into any health insurance plan. But whether it's state or private health insurance, it's important you do your research before you enter. Thank you.
Thank you. Okay, thank you. I think we can move on now. And I think I would go back to Dr. Rock. Okay, Dr. Well, you already have your hand up, so I will ask my question and you can take both at the same time. So I was going to ask about data on service utilization and patient satisfaction. Do you have this data, and how has this helped improve or inform policy and service delivery? Service utilization and patient satisfaction. Thank you. And you can respond to the previous comments.
Yeah, thank you again, Dr. Ameze, for set up everything. It's actually going to help us improve our processes. For data on service utilization, we're very big on data on service utilization. When we started, we made sure that whether it's primary or secondary service, we needed to have what's going on there, and let's know where we are lacking. The data is usually stored in DHIS of the Ministry of Health, and also backed up by in a cloud system with the health insurance. What we did is that we noticed that in the primary healthcare centers, the utilization was small. And so we decided to call all our enrollees, especially those under the Basic Healthcare Provision Fund, to tell them that, oh, provisions have been made for you for your healthcare service. And so this is where you are allotted to, these are the kind of services you can get. But we did a research sometime in the past, and we noticed that a lot of patients don't even know what benefits they have. And so we made it a point of duty, since we have their contact details, to send most of them the benefit package, all right, as text, as SMS, as email, so that they know what is accrued to them. And for patient satisfaction, I think I touched on that earlier while I was talking, saying that we have our desk officers dubbed in as our positive and early experience officers. One of the greatest index for checking patient satisfaction is the wait period, all right, but we should also have in mind the depth of human capacity across board, especially the medicals, the nurses, you know. And so when we have challenges that come from people having to wait excessively, or doctors not being around, we have to have a way of managing these situations. You can know the exodus. I mean, you're all aware of the exodus of medical doctors, nurses across board. And so we try to manage this situation using a good leadership style, so that, you know, they're like Gen Z, I'm sorry to say, you know, every minute they just want to step out of the situation. So we try to manage it so that, you know, healthcare is provided across board. For adverse selection that my colleague mentioned earlier, you know, talking about accepting all patients. When we started the health insurance in Edo State, we realized that, I mean, we checked on best industrial practices, and we noticed that false claims are the biggest fall for most insurance companies. And so there's something they say in law, those who seek equity must come with clean hands. And so what we do in our place is that we do a sort of pre-enrollment investigation before we get our people on board. It's not an elaborate investigation, but it's a point of care testing. People are not open to giving their medical challenges to non-medical doctors. And so we use the doctors and the nurses within our facilities to do a pre-enrollment investigation. Be that as it may, if they come down with very chronic conditions, we're not going to reject them because they are, you know, they have chronic conditions. What that pre-enrollment investigation does, and the slight history we take before enrollment, is that these enrollees are sent to the specialists who they require. Across board in our state, one of the first things they did was I would profile a lot of doctors, all right, based on their proficiency and their specialty. So if we do an investigation, a pre-enrollment investigation, you give us a history of having sickle cell, cancer, as the case may be, we are going to attach you to a medical professional who has that broad knowledge, all right, so that you can have holistic and good care, quality of care. For the authorization for emergencies in Edo State, also what we did was that if you have an emergency, whether surgical or a medical emergency, you do not require authorization to be treated by our healthcare facilities. For those facilities that have been engaged, we have an appropriation where somewhere where the money comes, where they get we have about 2 or 5%, I think it's about 5% for those who are not enrolled on the scheme, so that when they come into your facility with an emergency, you should please treat them. And even though you have exhausted that appropriation that is given to you, about 5% of what you get, you should please treat them, because we say that in our state, we don't want to lose people to life-threatening emergency, limb loss, or, you know, things that can, you know, distort their quality of life. So for us, we've had a lot of cases where we take care of emergency cases without having to wait for authorization. And we're also telling our colleagues across board that that's the right way to do, and a lot of them have instituted it. So that is helping our retention rate with the insurance scheme and bringing a lot of trust where, you know, on a daily basis, we see an exponential increase of people joining the insurance. It's an ongoing process, and we'll continue to do that, and we'll continue to hear feedback from our research that we can improve the processes and make the quality of service better for them.
Great, thank you very much. Okay, I would like to call on the World Health Committee member who's here, Mrs. Awoyemi Funke. My question is, what is the experience of your community members when they go to these health facilities, especially under the state health insurance schemes, PHCs that are accredited for basic healthcare provision fund? What feedback do you get from the community members in terms of quality of care, availability of services? Yeah. Thank you. Did you hear me? It's just no.
Can you hear me now?
Yes.
Okay. I said, I greet everyone, NSSF team. I appreciate you and others in this ongoing meeting. I'm a member of the World Health Committee for Igbogobayiku LCDA PHC. Concerning the quality of care we talked about, I would like to say, well, there is a great improvement. Honestly, there's a great improvement in the staff's behavior. You know, there was once a time when they will be hostile. You know, this aggressiveness that they cannot manage. They bring it to the office and you are like, God, I'm supposed to come to a place of comfort. I'm supposed to come to a place where people are supposed to console me and tell me what I've brought is not a big deal, you know. But once you meet with them, it's like facing a wall, a strong wall. That has changed, in honesty, that has changed. There's a great improvement in the staff's behavior to patients, no more stiffness. They have this soft approach, though it has to do with a lot of meetings, a lot of meetings, a lot of talking, a lot of encouragement. We let them know you have to put your own personal problem in your house when you're coming. Don't let it reflect on you officially. It took a while, but it's paying off. And just this little effort has paved the way for increase in patronage. Increase in patronage, people come to the health center, they even come to discuss health issues. Some health issues that they don't find convenient to talk about earlier, they do that now. And even the staffs themselves, they are poised for this. Some even come for heart matters. We are talking of quality of care. Yes, ma'am. Yes, ma'am.
Thank you very much. Yes,
quality of care. Yes, and then I'll also like to say that in our PHC, drugs are available anytime. Drugs are available anytime. Great thanks to SDRF. It's an NGO. They brought in drugs to the PHC, and we have been revolving it since then. Well, for antenatal patients, they have been given the delivery kits. Thanks to the government for this. This is also part of the quality care they receive. We have, you know, this part of Lagos State is unlike the island, is unlike the mainland. We have people that migrate from some places, people that are just starting up, people that are not financially stable, people that don't even have, but they know they must have children, but they don't have what it takes to take care of them. And they believe heaven will not fall. People must take care of my family. After all, I'm created to, my parents give birth to me, I must have my own children. So you know that kind of mindset. It's here, it's here. So
Thank you very
they
much.
have children, no kids to, nothing to really take care of them. So in the health center, the delivery kit is given to them whenever they come, and that is part of the quality of care they receive. On the part of the committee, because of the problem of shortage of staffs, majority of committee members work as volunteers. You may be shocked, but they work as volunteers. We are volunteers, we are ready to work, so we do it. We do it not looking back. You know, for the past 7 years, we have been rotating and supporting this. We have been doing this. We can't say because we don't have enough staffs, work will not go on. We volunteer and it is helping. It's part of the quality of care they receive there. We do lots of advocacy, emphasizing on the type of quality, the new level, the upgrade. We let people know. Those that were once discouraged, now they come, they realize that things has changed because of some of these things I'm talking to you about, and it's paving way too. It's helping us. Then there's this regular peace at the center. There's this peace. There's this peace. There's this peace among them. There's harmony among the staffs too, and it reflects on the quality of care that they give to people. The staffs come on time. They do come on time. Yes, they do come on time. When I get to the challenges we face, I will talk on some things. But despite those challenges, you know, the quality is increasing, is upgrading gradually.
Okay, thank you, Ma. So I think, so you can talk on the challenges now, but we should be rounding up within the next 12 to 15 minutes.
You're not giving me enough time, you know, you gave some people.
I'm telling you, I'm saying you can go into the challenges. I'm saying that it would also be good. These improvements that you talk about, what do you think has contributed to it? Is it more money from the state? Is it this health insurance scheme?
No, it's not more money. It's not more money from the states. I have not seen the reflection of this insurance scheme there. I have not seen it. You know, I'll say my mind. I've not seen it. I've not seen it. I'll say my mind. I'm talking of the efforts we are making here on quality of care. Our efforts. That's what I'm talking about. I've not seen. It's not reflective. This insurance thing is not reflective there. It's not reflective there at all. Part of the quality.
So let me just guide. So please talk about, like you said, your challenges and what you think the government needs to do differently to continue to improve quality of care and the health insurance scheme. Thank you.
You know, I talked about shortage of staffs. Presently, we have just 4 nurses and 2 doctors. There used to be 3. One has traveled out. You know, this current brain drain. One is gone. We are not sure of the others. We are not sure. We wake up, we ask ourselves among committee members, I hope they are still there. I hope the nurses are still there. I hope we still have the 4. I hope the remaining 2 doctors are still there. We are not comfortable. We don't know who is going. We don't know who will get the visa and go. We don't know. That's one of the challenges we have. Even the 2 doctors left, you know, they're on shifts. So when one is gone, the other has to be there. Whether he's feeling fine or not, he must be there. He just must be there. We make them, we encourage them to be available. And then in our center, we don't have major structures on ground. We have limited space, limited furniture, limited toilet facility. There are cases where the sewage, we have leaks, you know, and then the committee will bring in a civil engineer to do necessary work. We have that problem. Then there's this other make-up convenience structure built by one of our representatives, from the House of Rep, Honorable Jimmy Benson. This structure, ever since, it has not been commissioned. And it's a project that will help, really. It's a project that's supposed to help to let there be ease in administration. It's not yet commissioned over these years. I don't know. I don't know if I can talk to Dr. Olufemi Serrano He's in Lagos. He knows them there. It's not commissioned yet. I don't know what you can do about it. An NSSF team, please, you can do something about it. There's also a mini general hospital that the government is building there. Ever since it's still at the foundation level. It's still at the foundation level. Like I said, the community health attendants, they are only volunteers at the health center. And then the PhD does not have enough equipment in the lab. I expect the place to be a one-stop place. You understand, ma? I expect it to be a one-stop place. But for now, we just have testing apparatus, some little testing apparatus available. But to say we have a lab, no, we don't. We don't have scanning machine. People come in there, they give birth. We ask them to go and get the scan from somewhere else, which is not supposed to be so. Because of the caliber of people managing those labs outside. Who knows? Who knows? Most times when they come with a particular result, the nurses and the doctors get another thing entirely. They see another thing entirely that is contrary to the result they brought in from the lab outside. I believe it's not supposed to be so, ma'am. It's not supposed to be so. Then the security arrangement is terrible. We have just a megad over the clock. Whether he's fine or he's not fine, he must take drugs and be there. He's not even equipped. And we are in a time where people kidnap and sell body parts. The man is not equipped. He's just there. So that people will say, there's a security man there. There's a security man there. You know, but we know that the place is not secured. Then we don't have a standby ambulance. Most of these patients, they come in on bikes. It is in this area that I learned that when you are in labor, it is better they bring you on bike so that the bumps on the road will shake your whole body and it will make the baby to come out on time. You understand? I know it's not supposed to be so. We don't have standby ambulance here. We don't have it. We don't have it at all.
Sorry,
can I continue with the challenges? We have a challenge with finance.
Sure Dr. Serrano will follow up on this conversation with you. But I mean,
can you give me just little time, please? We have the challenge of funds. I expect that funds will come from the federal government to the state and directly to the health centers. But once it goes through some other channels, there is always problem. All these I've talked about, these funds should adequately take care of them. You understand, madam? Should adequately take care of them. We are not seeing the fund too. We are not seeing the funds. We are not seeing the funds. I don't want to say federal government is not sending it. I don't want to say it because I'm not there. But we are not seeing the funds. It's not working. It's not doing what it's supposed to do at the health centers. Most of the time, it is we committee members that go out there, go to people of means. Can you support us in this area? We go to some CDS. Can you support us? Some association come, they give us furniture. Some come, they bring in cards. Some bring in exercise books. Some do little, the little they can do. We appreciate them, but we know we need more. We don't have the mouth to say, give us more. It is what they have that they can give to us. You understand, right? It is what they have that they can give to us. Can I still continue?
Thank you. No, ma'am, we need to round up, but your message is clear. It's clear that
round up,
at the grassroots, we have a few more questions so that we've been here for a while, but your message is very clear. So the grassroots has not felt the health, Dr. Serrano, I'm coming to you, but clearly the increased health financing is not being felt at the grassroots. But thank you for your time in volunteering. Thank you to all the other members of the committee that are giving out time to ensure that people at the grassroots get these health services that they need. Dr.
I'd also
Serrano,
like to point out, I'd like to also point out that the volunteers are pure volunteers. No support from any angle. We are pure volunteers, even though we are open to support. We are very open to support. As at yesterday, we met and we are like, Is it not possible for us to get a vehicle and do so much advocacy? A vehicle, I run an NGO, majority of us have NGOs too. There are cases that we need to attend to, even dead in the night. And then we cannot go with our own vehicles. We are afraid of attacks. But if we go with a government vehicle, it scares people, it makes them to be on their level, it makes them to comport themselves. But if we go with our own, the fear of attack is there. We move into interiors dead in the night. When a woman will call you and say, "He's killing me, oh, he wants to kill
Thank
me."
you, Ma. Unfortunately, I didn't see you earlier. We should have started this conversation earlier. And unfortunately, the World Health Committee member from Edo State had connection issues and couldn't join. It would have been interesting to know what's happening in Edo State as well. But your message is loud and clear. Thank you very much. Dr. Serrano, before you respond to that, I just want to add something I'm going to give you the mic, Dr. Serrano. Just hold on. I just want to add something because the state recently released a baseline assessment, which also, and this touches on the financing she's talking about. And part of the report showed that it showed only 50% of healthcare workers were responsible for managing the facilities accounting system. However, less than 50% used financial management tools. So the question is, how are we improving transparency and accountability? And also your report said that only about 34% of health facilities offered insurance. How are we improving these numbers so that we can actually access to quality healthcare? So accountability, financial accountability, transparency, which greatly ties to what she has said, quality services and improving coverage. Thank you.
Okay, thank you very much. To the madam in Igbo, to address some of the issues, kindly ask the medical officer of health in your locality to reach out to my office. Then we can address some of your concerns about the various issues that you have. Then with respect to the report, so the report addresses two different sectors. We had the private sector and the public sector. So for the private sector, we have the general hospitals. The general hospitals are fully managed by the medical directors. The financials are fully managed by medical directors. For the primary healthcare centers, there is some sort of discordance as per who manages financial. Is it the medical officer of health or is it the local government? So those are some issues that are still being worked on within the local government and the primary healthcare board space. For private hospitals, for private hospitals, it's the medical directors that manage the finances. And we know that from history, doctors are not exactly good managers. So those are some of the things on Lashman's part to improve their awareness in terms of financial management of healthcare systems and facilities. Lashman is actually involved in the training of healthcare facilities on what we call the business of healthcare. So there's a clinical aspect of healthcare and there's a business of healthcare. So Lashman is constantly training facilities on the business of healthcare. And the hope is that when the facilities understand how to run their businesses effectively, that will also tie into the statement made by the NHI representative who said that quality in the long run will improve profitability, essentially. So those whole things together are tied together. So it's something that the agency is currently working on. Thank you.
Thank you. Okay. Mr. Awayemi doesn't seem satisfied with your response, but he has said you should reach out to his office.
That's the only consolation. We will reach out, sir.
Thank you very much. Thank you, everyone who has participated so far. We had a few questions for FCCPC, but I see they've dropped off. I know some of the questions in the Q&A have been answered. If there is no burning question, I think we can take, fine, let's see. Okay, unfortunately, Dr. Curfew is no more here. I would have directed a few of the questions in chat box to him. But can we take final words, please? Let's start with Barrister Ngozi Ndukauba. Thank you. Any final words, final comments? Thank you.
I'm an ardent believer in health insurance, and I'll quickly share a personal experience that I had. You see, when sickness is going to come, it's not going to send you a letter. It's not going to announce itself and say, look, I'm on the way, I'm coming. It can happen anytime. And we know the times we live in, money is scarce. I doubt if anybody, when drawing up a family budget, we include budget for treatments for one sickness or the other. So the best way to handle this is to pick a health insurance plan that can afford you access to healthcare when you need it. And I'll quickly share a personal experience. I was 6 months pregnant on a Monday morning, dressed up, and I went to work. I was working with NDIC at that time, and my water broke in the office. 6 months pregnant. I was rushed to the hospital. I didn't have a health insurance plan at that time. And for the next 4 months of my life, it was from one hospital to the other because the baby was preterm. The baby had to stay in the incubator, and it was a highbrow hospital. I was paying for my bed space. I was paying for incubator. I was paying for meals and all of that. And my husband and I didn't have any huge savings anywhere. We just got married. It was just before our second wedding anniversary. And this was our second baby that just came, that we didn't really, in quotes, plan for. God blessed us with it. So what I'm saying is, everyone needs a health insurance plan. And the good thing about health insurance is it's not a one plan fits all. Pick the package or pick the plan that you can afford. And when your life, your finances improve, you can go for a higher plan. And if somehow you find, you go for a lower plan. So that is the best thing for every Nigerian. Pick a health insurance policy, because sickness is not going to say when it's going to come. Accidents happen almost on a daily basis on our roads. And the only way that you can actually secure the healthcare of your family is to pick a plan. And if you work for a company, most companies, health insurance is mandatory, and I know it says if you have, it's mandatory. So if you're working for an organization, the organization should be able to pick a health insurance plan for you. If you're self-employed, pick a health insurance plan for yourself and your family. Thank you so much.
Thank you very much, ma'am. Okay, I'll go next to Dr. Amego, but quickly, as you give your last comments for both Dr. Rock and Dr. Serrano, there's a question on how you'll address health-seeking behavior amongst those who are willing to pay. So just tie that into your final comments. Thank you very much. Starting with Dr. Amego.
All right, thank you again, Dr. Ameze. For us in Edo State, people who have good health-seeking behaviors, we'd like to follow up with them. We had seen them during the COVID era. We had their phone calls, and we regarded them as our first adopters. So we made phone calls to them, and a lot of them, about 60% or so, were able to join into the health insurance scheme. And so these early adopters, we know that they can be people who would spread the good news about health insurance, to know that it's a win-win for the society, for the government, and for all. On a final note, insurance is a game of numbers. I would advise the general public and our residents and people in Nigeria that every time they make appropriation, they should appropriate for health insurance. Illness is it's not a respecter of gender, it's not a respecter of age, it can come anytime. And so when you are insured, there's even a psychological stability that you feel, all right? You're not going to get into the poverty trap. You know that when catastrophe comes, there's somebody to hold your back and there's somebody to hold your hand through the process. So for us, we advocate health insurance daily, weekly. It is what we do, it is what we will continue to do to get universal health coverage in Nigeria. Thank you.
Great, thank you very much. Dr. Serrano, please.
Yes, as a closing remark, as a closing thought, what I'll say is that with the passage of the new NHIA, it is mandatory for everybody to get health insurance. Now, what I'll recommend is that irrespective of your economic situation, you at least buy the state health insurance. Start with some. If you don't trust government, start with a little risk investment by buying your various states health insurance. If you are living in those states, buy those states. If you are living in Lagos State, buy Lagos State. As I know that you get good quality of service, you can then explore and get larger and more coverage from health insurance. And rest assured that health insurance is the way to go. I cannot start giving examples at this time, but rest assured that health insurance is the way to go. Thank you.
Thank you very much. And then Ms. Tonya Adeshola, your final comments, please.
Thank you very much, Amazing. Definitely, I agree with all the participants all the speakers, that health insurance for us, the experience with health insurance has been pretty good, despite all the challenges. It saved us in a lot of ways. That's why I encourage everybody to be on some form of health insurance. At least for a start, it can cover some areas that need support. Because the truth of the matter, like they said, health issues don't just pop up. Health issues just pop up, and they can create a dent in your financials if you are not prepared. So it's very important that don't look at it as, why am I giving 1 year to something when I'm not feeling ill? I learned something, that even though you may not be as ill as, and we thank God for that, but sometimes even being on health insurance can help another person. So I encourage everybody to be on health insurance. Thank you.
Thank you very much. Thank you everyone for your final words. I think a few of our panelists have dropped off, but thank you for your contribution. I would just allow Dr. Fejiro, are you still here, to give the final remarks on behalf of NSSF? Dr. Fejiro, are you still with us? I know she mentioned she might have to drop off because of network issues. Okay, since we haven't, she might not be there. So as I said, thank you very much. We appreciate your time. We thank you for your contribution to this very important conversation. The conversation doesn't end here. We will continue to advocate. We will probably be reaching out to support in one way or another, especially to our state health insurance schemes. Please, we had dropped a survey in the chat box. Feel free to take the quick poll. It would just help us know people's attitudes towards health insurance as we continue to advocate and design interventions that we would be supporting in terms of health insurance. If you have any more questions or comments, feel free to email us. Feel free to drop them in the chat box. You can check us out. Our website is www.nssf.ng. And we are also on social media on Instagram and Twitter as NSSF_NG. On LinkedIn and YouTube, we are Nigeria Solidarity Support Fund. Thank you and have a great day. We are looking forward to any extra comments that may come our way. Please let us know if this has been working well, how we could have made it better, or any comments. Thank you very much and have a beautiful day. Thank you, Dr. Work. There's a survey in the chat box. You can just click on it. Thank you.
Thank you, Ameze. Have a good day.
You too.